Hi there. Thank you for joining us today. I'm Marche, the webinar director here at Advice Chaser. Very excited to have you here today to learn about this important topic. Before I introduce our guests and get started, I do need to do a little bit of legal housekeeping. Advice Chaser, the host of this webinar, is not a registered investment advisor. We cannot and do not give financial advice. Today's presentation is for educational purposes only and cannot be considered advice for any person's individual situation. Advice Chaser regularly hosts informative webinars, such as this one, featuring a variety of knowledgeable professionals, many of whom are licensed advisors. Any opinions, ideas, jokes, or principles expressed by presenters are their own, and however true, funny, or interesting, are not endorsed by Advice Chaser. Please do not act on the information you hear today without consulting a qualified financial professional. We're thrilled to bring you this educational presentation today, Aging Independently with Dignity and Planning for Long-Term Care Needs, and a couple of housekeeping items for our attendees. You are muted, but we do encourage you to ask questions using the chat box, and the presenter will answer those queries during or after the presentation today as appropriate. If you ask a question in the chat box and we're not able to get to it, go ahead and leave your phone number as well. If we can't get to your question during today's event, we'll make sure someone reaches out afterwards to make sure that gets addressed. Again, we want this experience to be as educational as possible. So again, please don't hesitate to ask for clarification or to ask for expansion of the material. I'd love to introduce you to our guests today. Mark Seither is a partner and wealth manager with Kingsview Partners in Knoxville, Tennessee. He has a Bachelor of Arts in Economics from San Diego State University and began working as a financial advisor in La Jolla, California. Mark enjoyed finding innovative solutions to clients' complex problems, and his desire to work with the entrepreneurial-minded helped him thrive as a financial advisor. As Mark honed his skills and as an advisor and a planner, he looked for a platform that would better pair with his desire to work with clients needing advanced planning and specialized fixes. He found his spot back in Northern California in early 2017 when he joined Trust CFO and assisted in integrating complex tax and estate planning with wealth and investment management. Since then, he has collaborated with Josh Saunders to build Kingsview Partners, and together they assist individuals on wealth management and tax strategies. And Mark, why don't you come off of mute and say hello? And I know you have a couple words.
Hey everyone, so glad that we can have you all on today's webinar. I would say today's topic is, if you're looking for detailed product descriptions, this is not the webinar for you. This is more so going over the complexities of long-term care, how it plays into typically people's financial plans. And really, I'd say most of the time, you see a insurable need and it's very easily understood. This one's much less understood. So we're very grateful to have Peter on to give us a good breakdown of how the aging independently with long-term care needs plays a role in people's life throughout their life.
Thank you, Mark. Well, our presenter today is Peter Lofgren with Signal Advisors. For over 20 years, Pete has partnered with financial advisors and consumers as a subject matter resource on various topics, including long-term care risk mitigation. Prior to his current role as a VP, life insurance at Michigan-based tech startup Signal Advisors, Pete held various distribution leadership positions at one of the world's largest global insurance companies, Allianz. He has earned both CLTC and LTCP designations and served as an instructor for Minnesota's LTC Partnership, a medical assistance training course. And Peter, it's a pleasure to have you here. We're really excited to dig into this topic, very vital, I think, for not only, people going, looking at their later years, but their kids and people who are even in their younger years want to be prepared.
Outstanding. And thank you for that great intro. I usually, I just get somebody introducing me by name and not a lot of background context.
Launch
but I think
into
it's, I like that, I like the way that introduction's made, because it provides the folks on the line with the context that this is by no means my first rodeo. I've been active in the long-term care planning space for the better part of the 20 years I've been in this business. And this is my favorite topic to talk about. Hands down, it's one of the most sort of under recognized and certainly most frequently not addressed financial needs or financial risks people face as they're starting to look at retirement, preparing for retirement, or even navigating that part of their journey in retirement. So I'm very happy to be able to provide some education around this topic today. And of course, if there's any questions, please feel free to just drop those into the chat. Mark will interrupt me midstream and we'll answer them as we go, or we'll answer some of them at the end. We'll just see how it all shakes out. So again, the topic today is aging independently with dignity, how to plan for long-term care needs, give you some general education just around what long-term care is, the different ways that we address that, and just considerations around how you might apply these topics to your own situation. All right, so we can go ahead. So the first thing that we want to do before we get too far into this conversation is just create some shared definition around chronic illness and what long-term care assistance really looks like. Because I think people have certain preconceived notions about what long-term care is. But oftentimes what you'll find, especially if you experience this directly through a loved one or a friend, or, you'll find that it's a little bit broader than most people understand until they're at the doorstep, right? So what we'll start by talking about is, this is the federal government's definition of long-term care, which by extension means a lot of times when we're looking at solutions or different programs utilized to pay for care, it's going to cover this type of care using a shared definition. So activities of daily living, or ADLs for short, are the benefit triggers that federal programs, state programs, insurance programs all utilize as their common lexicon. And there's 6 of them that are codified, listed out on this slide. The easiest way to remember this is it's the things that you do in the first 20 minutes of every day. You get up. If the bed's dry, you've already satisfied your first ADL. Second ADL is going from a prone position into seated, and then seated to standing. That's what's collectively defined as transferring. So can you get up out of bed without assistance? Toileting is going and using the bathroom successfully. Don't need to go into a ton more details there, I don't think. But incidentally, toileting, one of the things that becomes most difficult as we age is the getting, again, up and down off of a seated position. So that's the part that presents the most difficulty for most folks. Bathing, this is defined as getting in and out of a bathtub. So even if you're a shower person, as I certainly am, bathing under the federal definition codified in the tax code is defined as getting into and out of a bathtub and cleaning yourself without assistance. After that, you get dressed, and then ideally you head to your kitchen, have some breakfast. So in the first 20 minutes of the day, you've satisfied all 6 of your ADLs. Can we go back to that one for just a second? So I'll ask this as a trivia question, because normally in a live group, the first trivia question I ask through the presentation is, if you had to take a guess, and since I can't poll the audience, I'm just going to ask Marche and Mark, if you had to take a guess, which of these 6 ADLs do you think for most people is the first one to go? No pressure.
Would it be bathing?
Ding, 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 ding. Yes, bathing is the first one to go. Do you know why that is, Mark? What's your logic behind making that choice?
Well, I know I have a bum shoulder and I already have a hard time getting spots on my back.
So it's not actually the cleaning part of it. It's the safety element of getting into and out of a bathtub. It's a wet, slippery surface. And so if you already have some instability in your standing or movement, that will exacerbate that problem. So activities of daily living and the assistance tied to it actually is defined again. So this is common lexicon across all these programs. It's defined as arm's length assistance. So in order to safely execute that maneuver, you need to be able to do that without somebody else at arm's length, providing support or being there for safety. So yeah, bathing is the one that typically goes first. It's because of that wet surface element. All right,
And
let's go.
Oh, I
go
just
ahead.
had one question here. So I'm assuming transferring might also be related to that. Come next after that. If they have trouble getting up and down, that sounds exactly where that lies too.
Yep, those two go part and parcel. If you start to have difficulty getting out of a chair without somebody, kind of helping you and assisting you for safety and stability, chances are good bathing, those go part and parcel. Now, the next kind of consideration in needing some care as we age, this is actually not something that's codified, but it's useful to think about it in the context of things that you might need help with. So instrumental activities of daily living, or IADLs for short, are all of the various other supporting functions and tasks that we go about in our daily lives that might become more difficult as we age to do independently. So things like going to the store and getting groceries, balancing your finances. They used to call this balancing your checkbook, but then we found that people were like, what's a check? Nobody uses a checkbook anymore, but maintaining your household finances, just keeping up your household, whether that's cleaning or doing your laundry. These are some of the things that oftentimes can be a leading indicator that assistance with ADLs might not be far behind. So for example, if you notice that an aging relative or family member is starting to have some issues, keeping up with their laundry or their housework, that may be an early indicator, an early sign that they may not be too long before they need a little bit more substantial assistance. I'll say too that all of these definitions, now there's a difference between acute care and long-term care. So acute care, let's just say for the sake of example, I'm out riding my bike and I fall over, I get into some kind of an accident and I break my leg. I might need help getting dressed. I might need help getting in and out of the bathtub. I might need help with my ADLs. That wouldn't be for me as a 42-year-old a long-term care claim. And the reason that it's not a long-term care claim is because unless I get real banged up, I'm likely to make a full recovery within 90 days. Now, if I go past 90 days and I need more ongoing care, if I need more time to heal, that's where we go into long-term care or chronic illness. That's the definition, is that 90-day mark. And one other thing I wanted to bring up is that all of these different care needs are immediately short-circuited if a person has demonstrated cognitive impairment. So if somebody has cognitive impairment that's expected to last 90 days or longer, they might be able to conduct all of those ADLs independently from a physical capability standpoint. But if you can't do that safely on your own without supervision because of cognitive impairment, that also qualifies as being long-term care benefit eligible. This, I think, is another topic within just the broader definition of long-term care that people don't always fully understand or appreciate until they have somebody that's going into a long-term care need. And that's where and how you receive care. So I think a lot of us just sort of intuitively understand what a nursing home is and what sort of care services are provided in a nursing home. But the reality of care in the United States is that very little of the care that's delivered for long-term care or chronic illness purposes is delivered in a full institutional, residential, custodial setting like a nursing home. Far more common are situations where you have a home health care provider coming out, or somebody living in a sort of spectrum or gradient of care needs, where they're not in a full custodial setting, but they're maybe in an assisted living facility, where they can get some help with maybe some of those IADL services that don't rise quite to the level of care of an activity of daily living. And we talk about that when we look at trying to plan for the need. The resource needs of somebody who's in a full custodial setting or 24-hour care at home, that's a very different economic footprint than somebody that just needs a little bit of help each day getting going, or maybe just a little bit of supervision so they can be safe. We've seen a lot of more accessible and community-based care settings emerge over the last 20 years. Things like adult day centers. These are a fantastic way for people that have aging parents or aging relatives to have a safe, oftentimes really great social environment for those aging elders to be part of, and to be able to go and get the kind of assistance and support that they need during the day. And then at night, they can return home and be cared for by family members and live in that kind of a setting. So we've seen, kind of adult day centers really come into prominence in the last 20 years. Memory care is another one where this is something that I think if you looked back far enough in time, people would say, oh, well, that's a nursing home. And maybe 30 years ago, that was the case. What we're finding now is that there's greater and greater specialization being provided in different care facilities. So if you have somebody who's experiencing cognitive impairment, whether that's Alzheimer's driven or senile dementia or any variant thereof, memory care centers have a little bit different type of staff specialization. Some of them even have a different physical design to the facility. I've been in memory care centers before where everything is structured to be a loop, so that if somebody's a wanderer, they'll always kind of come back around to point zero. And of course, there's always, safety considerations there too, right? Providing limited access for residents so that they can't accidentally wander off unknowingly and end up in an unsafe situation. So all of these things are worth considering as you're looking at your own potential future care needs and where and how you want to receive that care. Another definition related to the actual care delivery is whether care is being provided by a formal or an informal caregiver. So oftentimes, government programs, private insurance, those are going to look at paying resources to a licensed, certified professional caregiver. If you want to have your care provided by a family member or somebody who's an informal caregiver, whether that's somebody in your neighborhood or in your community, just be mindful that depending on the way you plan on providing for your care needs and for the expenses related to your care needs, you may or may not be able to compensate a family member for their time using some of those means to an end. And we'll talk about care funding in just a little bit in this presentation, because we do want to talk about the financial impact of long-term care. But for context, most of these ways to pay for care will very clearly define whether they're paying out benefits just based on a monthly amount or whether they're reimbursing you for skilled care. So again, just a planning consideration as you're looking at different ways to cover this need. So we've talked about what long-term care and chronic illness is, created some of a little bit of a shared definition. Now let's talk a little bit about how people pay for these needs. So when you need care, what does it cost? How do you pay for it? What are the different resources available? We're going to talk about not just things like private insurance or self-paying. I also want to make sure that we give some credence to public resources, government programs that are available to pay for long-term care. I think one of the greatest dangers that we face as a population that's aging is that there's not a great deal of conversation and there's not a lot of awareness of what the government does and doesn't pay for. So if you walk away with nothing else from this conversation today, you'll at least have a good sense for what actually is paid for. So most people look at it and they say, well, I'll be eligible for Medicare when I'm 65 and Medicare covers my healthcare needs, so I should be fine, right? Well, not exactly, not when it comes to long-term care. Medicare is public health insurance. So if you need things like medication in retirement, if you need things like paying for your doctor's visits, paying for treatments for your health conditions, paying for a hospital stay, that's what Medicare is there to provide. That's the public insurance element. We want to have a healthy aging population, but really Medicare is meant to provide medical care. Medicare does have a very limited amount of resources available for long-term care, but the long-term care that it pays for isn't really long-term care. It's more of an acute recovery benefit. So if you think back to a few minutes ago when we were talking about the difference between a chronic illness and an acute condition, Medicare is covering the acute side. It's actually listed as a recovery benefit. So if you say live in Minnesota, as I do, and you're walking out of the grocery store one morning and you fall and slip on the ice, because we got ice on the ground 9 months out of the year, and you break your hip, Medicare's recovery benefit is intended to help you pay for the time that you might need to be in an institutional setting so that you can recover from that injury. In order to be eligible for Medicare's resources for long-term care, you need to have a qualifying hospital stay before you go into that recovery setting. If you meet the qualifications, certain number of days in a hospital, then going into a recovery setting, Medicare can potentially, I shouldn't say will, Medicare will potentially pay for the first 20 days of your care. From day 21 to day 100, if you still need recovery benefits, Medicare will pay for a portion of it, but you're on the hook for a daily copay. The daily copay a lot of times can be covered by most people when they go into retirement and take or enroll in Medicare, purchase a Medicare supplement policy. So a little bit of like overage insurance. Med sup policies, depending on which version you choose to buy, sometimes they'll have coverage for that copay. So, and I'm not a Medicare supplement insurance expert, but if memory serves, there's like A through J, and some of those, letters of the alphabet have that benefit and some don't.
I will
and there's
break in
various-
here.
Oh,
We'll
yeah.
break in here. We do have a couple webinars specifically about Medicare, and you can look on our website for those and learn more about those if you're interested.
Yeah, great topic. Again, super robust, very complex topic, worth knowing a little bit about if you're getting close to that age 65, mark. But I guess I share all this to say Medicare was never intended, and it will not provide for long-term care expenses, recovery benefit only. So the other public program, and by the way, Medicare is an entitlement program, meaning that if you have been paying into the system as a citizen and a worker in the United States for a certain number of qualifying quarters, you are entitled to that benefit. Medical assistance, on the other hand, Medicaid, is a needs-based program. It is not an entitlement program. You do not get it automatically. Medical assistance, and I'm using those terms interchangeably, medical assistance and Medicaid. In Minnesota, we call it medical assistance. A lot of states do. Medicaid is the federal umbrella that program falls under. So it's federally funded. It's administered at the state level. So every state has a little bit different rules, but they all follow the federal guidelines. So there's going to be a little bit of nuance based on where you live or where you live in retirement if you end up, needing care later in life. So just be aware of that. There might be some variety, and that's why I'm not going to drill into the numbers too specifically. Medical assistance is not an entitlement program. You have to qualify. And the way that you qualify is you prove that you no longer have any money. You prove that you've already paid out of pocket everything that you can afford to pay, and then the government will step in and provide for the expense of your care at that point. There's a couple of limitations with that, and it's worth pointing this out. Number one, if you are receiving care services that are being paid for by medical assistance or Medicaid, they will dictate where you're receiving that care. So you're going to go where there's an open Medicaid bed. Sometimes that will be like if you're on a long-term care claim and you're paying out of your own pocket, and you get to the point where you no longer have resources to pay for that care, sometimes they'll allow you to stay in the place that you are. It just depends on if that care setting accepts Medicaid payments and if they have a bed available that they can allow you to continue to reside in. And I say bed, but really I mean like a room and everything. Not all care settings accept Medicaid. In Minnesota, there's a high percentage of our medical, or I shouldn't say medical, but our residential care facilities that don't accept medical assistance payments. They've already got a waiting list of people that are willing to pay cash. Why would they take a reduced government payout for that care? So all of this is to say there's spend down happening, and only then are you eligible to receive benefits under Medicaid. Are you guys picking up that background chatter, by the way?
No, I don't hear
Okay,
enough.
sorry, something's going on upstairs. Forgive me. I think my wife decided to start vacuuming right in the middle of this.
That's okay. Can you talk to us about those abbreviations there? The
Yes, be happy
MMNA?
to. So you have two different additional considerations in medical assistance that become kind of germane to the situation if you're married. So MMMNA stands for monthly minimum maintenance needs allowance. This applies to income that the household is recognizing on a monthly basis. So if you have two spouses, one spouse gets sick, needs care, you're looking at, okay, how do we pay for this care? Can we apply for medical assistance? You can apply for medical assistance and have the program pay for a spouse, an unhealthy or sick spouse. I shouldn't use the terms unhealthy or sick, but an impaired spouse's care, and still have the healthy spouse living in the home and continuing to receive a certain amount of income. But the healthy, non-care needing spouse can't continue to pull in the same amount of income every month, because the government's going to say, a pretty sizable portion of the household's resources need to go to pay for that person's care. So the minimum monthly maintenance needs allowance in 2022, the minimum prescribed in the United States outside of Alaska and Hawaii, because there's a different level of care or income ascribed to those two states, is $2,288.95. So that's the minimum that Medicaid says a healthy spouse, community spouse, can keep in income. But the maximum the government will allow, because remember, this is a federal program administered at the state level, the maximum allowed for any state is $3,435 per month. So if you're a household accustomed to having a higher amount than $3,435 a month for your needs, that'll represent a bit of an adjustment. The other acronym, CSRA, stands for Community Spouse Resource Allocation or Allotment. That's basically the amount of assets that you're permitted to keep. So medical assistance requires not only spending your income in the household each month for the care needing spouse's cost of care, it also requires spending your assets down. Now, if you're a single individual, and let's say you have several $100,000 to several $1 million of assets, the government will require you to spend those assets down to roughly $2,000 of personal effects before medical assistance will kick in and start covering the cost of your care. If you are married, your spouse is allowed to keep the lowest CSRA in the US is $27,480 of assets. The highest is $137,400. So even if you live in a very high cost of care state in the US, the highest CSRA amount is $137,400. So you have to spend your assets down to that amount. Now, this is a little more complicated than I'm making it sound. There's certain allowances provided for home equity. You're not required to liquidate the house. There's other rules that come into play here, but just broadly speaking, if you are applying for medical assistance, you'll have to utilize a significant portion of your own resources before the government will step in. So that brings us to other ways that you can pay for this. And broadly, that's going to fall into two categories: self-paying or private insurance solutions. There's a lot of different ways that insurance companies have come up with to provide resources to pay for this care. So the first of these, well, actually, before we get into specific product types or specific solution types, there's different things that are kind of common across all the different solutions that are available in the private insurance sector. Some of the things that are common to all of those types of products are the bullets that are listed on this slide. So reimbursement versus indemnity. This is probably the most important distinction, which is why I put it as the first bullet. Some types of insurance products will pay benefits based on reimbursement. So if you're receiving care, you remember earlier in the presentation, we talked about informal care versus skilled care. If you're receiving care from a skilled licensed care provider, that's a reimbursable expense and you can submit it to the insurance company. They will pay you back. That's what reimbursement means. Indemnity is just insurance speak for cash. Indemnity policies base it on the insured party's state, if they're benefit eligible. Now, under the federal tax code, long-term care insurance policies all follow the same definition of benefits eligible, right? It's that inability to perform 2 of 6 ADLs or be certified cognitively impaired. So once that state takes place, private insurance policies that are based on an indemnity structure will start to pay out cash each month, just a defined amount specified by the purchaser. The next thing, once you've figured out, do I want to get reimbursement or do I want to get cash? The next thing to determine is how long those benefits should be paid. Now, the average length of time that a person spends in some type of a long-term care setting or need historically has been a lot shorter than it is today. As medical technology advances, as our understanding of how to care for people in an aging environment advances, we've seen this amount of time that people spend in a long-term care setting get progressively longer and longer. When I first started my career in long-term care planning and in different financial applications of that problem, the average was about 2.4 years. I think at this point, we're getting up closer to 4 years, depending on which source you consult and where they measure the start of that care need. But generally speaking, you want to make sure that you're providing enough resources to pay for 3 to 6 years of care. And if you have longevity in your family, you might want something that pays for longer. Elimination period is a deductible. A lot of times people will ask, okay, so when I think about the other types of risk mitigation products I have in my financial portfolio, when I think of my auto insurance, which I actually just filed an auto insurance claim this morning. Thankfully, it was a windshield.
Oh, well,
Glass,
that's good.
no deductible. Yeah, you got to love that when it happens, right? And I'm sure I'm paying for that somewhere. But people will ask, okay, well, if I have a long-term care insurance policy, what's the deductible? What am I required to pay out of pocket? You know, going back to the topic we were talking about a moment ago, Medicare, you have a deductible and you have a copay, right? In long-term care insurance products, different versions of this product, it's typically called an elimination period, which just means that the insured is responsible for paying for the first set number of days of care. Now, historically speaking, when people are overlaying their Medicare and their private insurance, they know that Medicare, if they have a hospital stay first, Medicare is highly likely to pay for 20 to 100 days of care. So it's a very common thing in the industry to see 90-day elimination periods as a result. The other reason for that is most people could afford to pay for their care out of pocket for 3 months from assets or income or some combination thereof. And it's just, you know, sort of a natural point of like where people are comfortable, right? Auto insurance, you see people with $500 deductibles or $1,000 deductibles. It's just what the industry kind of priced out. Couple other things to consider from a private insurance standpoint or product feature standpoint, if you're looking at that as a way to fix that problem. Daily versus monthly benefit payouts. So do you want to have payments being sent monthly or do you want them daily? The benefit of having a daily versus monthly limits are a little bit more flexible if you're receiving intermittent care. So if you have somebody coming to your house a few times a week to provide care services, having a solution that has a monthly benefit limit gives you more flexibility than a daily limit. And then the last thing I'll mention is inflation protection. We know that the cost of care has continued to increase, as has the duration of care most people need. And as a result, you can build your policy or you can build your solution if you're using insurance to have a component where the benefits increase over time. Highly valuable feature, frankly. I wouldn't encourage anybody, unless they're pretty advanced in age and you know, putting something in place much later in life, If you're in your 60s or 70s, or certainly any younger, inflation protection is an absolute must. The cost of care survey piece of this is, I haven't mentioned this yet, but the cost of long-term care services are highly localized. I could cite national averages for what it costs to reside in a single occupancy nursing home room, for example, or what the hourly rate is for a home healthcare provider in Minneapolis, or how much it costs to live in an average assisted living facility in California. Averages lie. Oh, they lie. It's a very dangerous thing to base your planning around the cost of care in the entire United States. I don't know if you've noticed this. The US is a very, very large country. And the cost of things, I mean, even look at the cost of gas. Mark, what's the cost of gas in your area in California today?
Oh, well, I'm actually in Tennessee today.
Oh, shoot. Yes. I'm sorry.
Yeah,
I forgot.
No, but I did, had to have been a month ago where I talked to someone back home after a trip, and they're like, yeah, I just bought gas for like $5.60. Yeah.
Yeah, we finally floated under $4 a gallon in Minnesota today, but my sister lives in Southern California, and it's not uncommon for them to be paying in the $6 and $7 range recently. So cost of care is hyper localized. And it's also very dependent on what level of skilled care you need, if skilled care is what you're after, right? So here's a trivia question for you. And I mentioned this to you two before the webinar started. What state do you think has the highest average cost of care?
I mean, when you think about highest average, you think about, the coastal cities, New York, California. I'm assuming that would be pretty high.
And they are on the higher end of the spectrum, for sure. But for all the times I've asked this question, I've only had one group that's ever gotten it right. On the first hand goes up, they guess it. Because you typically will hear, oh, well, it's probably New York or Connecticut or, California, maybe Southern Florida. And I'm sure some of those places, there are probably pretty expensive places to receive your care. But on average, the state with the highest cost of care is Alaska.
Huh.
And the reason for it is just simple supply and demand economics. There's a demand there, and they just don't have enough caregivers. And so the cost of the caregivers, if you're in the caregiving profession, I tell you what, move to Alaska. Apparently the rates there are very good. But that's what it comes down to. And I would say even in your immediate area, there could be a broad range of cost, right? From the most basic care setting up to, the creme de la creme, continuing care retirement community with everything from residential non-care all the way to full custodial care. So do a little research. If you want a publicly available resource to look into this on your own, Google Genworth Cost of Care Survey. Genworth was one of the biggest private long-term care insurers for many, many years. They don't offer product now. They're not in the business of selling long-term care insurance any longer, but they do still publish their cost of care survey every year. It's the most comprehensive resource I'm aware of, and it's publicly available and it's free. So Genworth Cost of Care Survey, they update it every year.
Now, we had a question come in regarding the reimbursement and indemnity. Someone asked if I'm going with informal care, would the indemnity allow me to hire a family member for informal care versus formal care? Yes.
And I stay away from using the term hire a family member. We compensate them for their time, right? That's just me being fun. But yes, that's a great question. If you're looking at being able to provide resources to a family member in exchange for providing for your care or stepping away from their, work or family to be able to do that with you, you absolutely want to have an indemnity policy in that scenario, because reimbursement will require the person administering the care to be licensed and certified. Great question. So we've touched a little bit on some of these earlier. So Medicare supplement insurance, again, not meant to provide for a longer period of time than 100 days. MedSups are really just going to help you cover the copay or the deductible. Traditional long-term care insurance, this is what most people think of when they hear long-term care or long-term care insurance. It's a traditional design product where you pay a monthly or an annual premium for as long as you have the policy. And if you need care, the policy pays for a daily or monthly benefit for a set number of years, probably has some degree of inflation protection in it. These products were the sort of be all end all in the way that everybody solved the problem 15 to 20 years ago. And at this point in time, there's very few companies that still issue this type of insurance. It is still a good option if you're looking for the highest degree of customization and the lowest initial cost. Over time, one of the challenges with traditional long-term care insurance is that the policies that people bought 10, 15 years ago have gone through several rate increases. There's really not a lot of options now. If you're looking at buying that coverage new, I think there's only 2 or 3 carriers that offer it in the independent space. They're almost always reimbursement policies. And if you don't ever end up needing long-term care services, they typically don't return any value back to you or your heirs, which for a lot of people is, something that they're concerned about, because you might be spending several $1,000s a year on this type of insurance only to end up, passing away peacefully in your sleep, like we all hope happens, right? If that happens and you don't file a claim, then it's money you've spent for protective benefit. It's not like you've got no value for that premium, but you don't end up getting anything back typically.
And so this would be just a question here. This would be what was traditionally the long-term care insurance option, say 10, 15 years ago.
Absolutely. Yep. I would say the industry sales of traditional long-term care insurance probably peaked about 15 years ago, maybe 20 years ago. Was right when I was actually getting into it. I joined during the heyday and it just all went downhill from there. But you've seen a lot of companies that used to issue that insurance exit it. It's really hard for an insurance company to offer that type of policy and still be profitable. And the reason for that is that long-term care insurance has a very, very high incidence of claims. So when people buy the insurance, they don't tend to let it go. They tend to keep it until they actually need it. And when they do, they're getting back a lot more value than what they paid in premiums, which for an insurance company is not what you're looking for. Insurance is meant to spread risk over a very wide pool of people, some of whom will need benefits, but many of whom will not, right? So one of the other things with traditional long-term care insurance that can be a beneficial way to use that type of policy, if you have a well-funded HSA, which not everybody has going into retirement, but if you're in a position where you do, you can utilize unspent HSA dollars for the purpose of paying a long-term care insurance premium. Or if you're still in your working years and you just want to put a solution in place that utilizes traditional long-term care insurance, any tax qualified long-term care policy can be paid using HSA dollars, and it's still considered a tax-free expense. So you retain that tax benefit of the money that's been accumulated inside of that HSA. So just another reason that you might look at traditional long-term care insurance or look at riders that are considered tax qualified long-term care insurance riders.
All right, well, let's just go ahead and talk about those riders. Here we go.
So 2 other ways to fix the problem, and sort of the more present day ways that we see this problem being addressed by private insurance. One way is to utilize riders on another type of financial product. So the 2 kind of common ways that shows up is riders on life insurance policies or riders on annuity policies. I tend to think that that's a great way for your dollars to do double duty if you already have a need for one of those other types of products. So if somebody's looking at purchasing insurance to provide for estate liquidity anyway, being able to tack on a rider that provides some long-term care or chronic illness resources just increases the utility of that type of solution. Ditto for annuities. If you're putting an annuity into your portfolio anyway to provide for retirement income, it's nice to be able to tack a rider on that provides some additional, maybe accelerated liquidity or earlier access to pay for long-term care needs. The most common devoted or focused way to solve long-term care planning needs is what are called collectively asset-based or hybrid long-term care insurance products. So this would be you have a policy that serves as a long-term care resource. Usually these are being, again, built off of a life insurance or annuity chassis. And the way that it works is a person purchases this type of coverage. If they don't use it, it goes back into their estate as typically a death benefit. If they do need to use it, it provides a higher level or a greater amount of leverage to provide for care needs. These come in both reimbursement and indemnity flavors. You can typically put inflation protection on them. They can be funded through a one-time deposit of money or paid over time. Lots of flexibility, lots of different ways to fit that solution. But for folks that are looking at ways to create some leverage and be able to create some resources to pay for long-term care, it's oftentimes a very efficient strategy. Now, this is an interesting part in the presentation because I don't have a lot of bullets around self-insuring. There's really not much to it. And what's interesting here is that if you've never sat down and thought about what your plan is to pay for long-term care, I've got news for you. You do have a plan, whether you realize it or not. If you haven't set aside any other type of planning, this is your plan. Because absent some other type of instrument or some other type of tool that you're going to utilize to pay for chronic illness or long-term care needs, you'll be paying for it out of your own resources. And there's nothing wrong with doing that per se. There are a lot of people that figure out how to pay for their care needs from their assets or from their income in retirement. And I would say, you know, once you're past a certain amount of resources, you could probably afford to do this. But is that the most efficient way? Is that the way that you want to pay for those care needs? So that's, again, a personal choice that none of us on this call can make for you. But absent any other plan, self-insuring is your plan. And again, be very cognizant of the fact that depending on where you want to receive your care and how you want to receive your care, there may be reasonable to unreasonable costs associated with that. The other thing that I try to make sure that I remember to call out when we're talking about self-insuring, paying from your own assets or resources, this can get a little bit tricky if your accumulated wealth is represented by a lot of illiquid instruments. So for example, in my part of the world in Minnesota, a lot of families have cabins on the water. We got a lot of lakes up north. People like to get a lake place for fishing or, you know, boating or just being out, you know, in the sun. If that's a big part of your wealth, real estate or other illiquid assets, if you need money to pay for care, liquidating those under duress oftentimes leads to, well, in the very best case scenario, it leads to trying to find a way to keep it in the family without running afoul of Medicaid spend down rules. Worst case scenario, you end up having to list it and sell it under duress, and you get a lot less value for it than it might be worth. We didn't really talk about Medicaid spend down rules, and I don't want to get into that because that's a topic that we're definitely not going to be able to cover in the time we have left. But broadly speaking, if somebody's spending down assets for the purpose of qualifying for Medicaid, there's a 5-year look back on any gifts. So if your plan was, well, I have all these assets and I have all this property and I have all these things that belong to me, if I get sick, I'm just going to give them to my kids and then I'll be impoverished and I can qualify for medical assistance. It's not how it works. The government will look back at any transfers you make to another person or to a trust for 5 years preceding the date that you apply for medical assistance eligibility. So there's really no ability for people to just give their money away and then qualify for medical assistance. So next steps, what I would encourage everyone on the call to do, if you're listening to this live or if you're listening to this as a recording later, take a moment, you know, even if it's just 5 or 10 minutes, to think about what you would want. What are the things that you would want if you ever needed help with your activities of daily living? What would you ever or how would you ever want to receive help or care should it come to that? Where would you want to receive that care? Do you want to stay in your home? By the way, as much as you'll hear about people talking about, well, it's about maintaining your independence and aging in place, Not everybody wants to have a stranger coming into their house. Home care may not be for you, and that's totally okay. It's a personal choice. You may think, you know what, it's a lot better for me personally to go into an assisted living setting. Or maybe you want to go into somewhere where you've got a gradient of care, where you start in an independent living setting, no care at all, and then you graduate to assisted living and ultimately maybe to a full custodial care setting. Places like that exist. So I would encourage you, go out to the cost of care survey, see what it costs in your area, generally speaking, and then start just Googling different options in your area. You'll get a really good feel for what the cost of care could be, and it'll start getting you thinking about how you might want to plan for that so that later in life, you've got a good idea of what's coming. And of course, anytime that you need advice or you're looking for more information on that, the folks on this call are more than happy to help. That's why, we want to be able to provide education. But with that said, that's all I had as far as the educational content today, and we'll be happy to answer questions if anybody has anything.
All
Perfect.
right.
We did have a couple come in.
Outstanding.
So one was, if I need home improvements for my daily living, is that covered with long-term care insurance?
Well, here's where we need to define home improvements. If you don't like the color of your house paint, that's probably not going to be covered. But if you need something like, I'm guessing what the crux of the question is whether long-term care insurance would pay for things like home modification, safety rails, ramps are very common, maybe changing the type of flooring to accommodate assistive devices, whether it's a walker or, quad cane or a wheelchair. Generally speaking, private insurance does have benefits available for that type of modification. Whether that's traditional long-term care insurance or asset-based long-term care insurance, usually there is some type of a home modification benefit. It might be prescribed as a specific percentage or a specific dollar amount. Of course, with indemnity policies, you don't have to worry about that because you're just going to start paying out monthly amounts per what the policy says is available. And those could be used for home modifications. But that's a great question. And for what it's worth, that's probably the single best thing that you could do with your money to maintain your independence, is just make a couple of tweaks to your house so that you could stay at home and be able to continue to function without a lot of extra help.
Mm-hmm. And then we had another one come in about, you talked about qualifying for care when cognitively impaired. What certifies a person as cognitively impaired? Yeah,
so that's another great question. The way that that's typically written in from a certification standpoint is that your physician certifies that you are not able to live on your own without a substantial level of supervision. So it's a little squishier than the ADL definition, but it's generally just your doctor saying, yeah, such and such can't really be alone anymore. I hate to say that, you'll know it when you see it, but you'll kind of know it when you see it. It's like if you've ever dealt with an aging relative, I can say from my personal experience, both on my mom's side and my dad's side of the family, unfortunately, and on some of my wife's relative side, we've had some folks that have had different types of cognitive impairment. And when you know, there's usually an event that kind of opens everybody's eyes, and it's pretty easy to get certified once that takes place.
And then another follow-up question was, if someone goes on long-term care, if they're receiving a benefit, but then recovers to the point to where they're not qualified anymore, does that impact their benefit if they were to go into another long-term care event?
So that's what you've just described is what used to be called recovery benefits or a recovery rider. So traditional long-term care insurance years ago would often include a provision that if a person ended up filing a claim and then making a full recovery, there would be a restoration of those benefits that were used. It's not as common to see anymore. I think you could probably still track it down in certain types of products. But if you're looking at a policy that you bought in the past, for example, it's highly likely, if that's more than 10 years old, that there'd be a restoration of benefits provision in there that would restore any used benefits upon a full recovery. most of the solutions we see being put in place today, it would be, you use up a certain amount of your benefit pool. If you make a recovery, great. But then, any unused benefits are still there, but it doesn't like re-up the benefits.
Got it. And then another one came in. At what age do most people look at and implement a long-term care policy?
So most long-term care planning tends to take place, and we were talking about this a little bit before the web seminar started up for everybody. For better or worse, most people start planning when they go through it with a parent or other relative that's close to them, right? So as soon as you have somebody in your family that goes through the long-term care process, that's what triggers most to end up starting to seek out answers for themselves. I will say, like, on average, and again, averages are dangerous and sometimes they lie, but on average, most people start to look at this and start to do some planning, even if it's just very cursory planning, when they're in their mid-50s to, up to about mid-60s. That's when it seems to be most common. But we see people addressing it, sometimes you're still working into your 70s and you don't take time to stop and think about it until you're already 72, 73, up to 75. Like anything with, insurance related to mortality or morbidity, the older you are when you start that process, the less leverage you'll get per dollar that you set aside to plan for the need. But it's what's the old proverb? The best time to plant a tree was 100 years ago. The second best time is today.
Mm-hmm. Yeah.
Which we had a follow-up to that last question, which was, when is it typically too late? As far as when do insurers, typically say, hey, this isn't offered anymore?
Sure. Depends from one insurance company to the next and one product type to the next, but typically about the oldest age that we can still put coverage in place to ensure that need is 80.
That's actually older than I
That's a
would've
lot later
expected.
than I thought.
Well,
Yeah.
and there are still some solutions that can be utilized for people up to about 85. So yeah, actually a better answer would be 85. But your spectrum of your constellation of solutions shrinks as you get more advanced in age, because there's fewer companies that really specialize in applying solutions to people that are 80 to 85.
Which I'm sure, just like Alaska, having the providers slim down to a minimum, the cost of said solutions probably increases. I don't know that for sure. I'm speculating.
Yeah, I mean, the insurance companies have been at this for a long time. They do understand that the more advanced in age you are when you buy a policy or put a solution in place, the higher the likelihood you're going to actually have it when you need it for a claim. Which is something that, if you're issuing a policy on a 45-year-old, anything could happen. So they're kind of pricing those things accordingly.
Got it.
It's never too late to look at it, but it's never too early to start.
Well, I was just going to say that's about all the time we have for questions. We're buttoned up right against the end of our time today. On behalf of Advice Chaser, I want to thank Mark and Peter for being here and for the organizations that have made this webinar possible today. Thank you so much for attending. To our attendees, look for an email soon with a link to the replay of this event. We've gone over a lot of important information, and you may want to watch it again or share it with friends or family. Here at Advice Chaser, we're all about helping you find a financial advisor who's a great fit for your life and your financial questions. Our matching service is free to you, and every one of our advisor partners has committed to offer a free initial consultation to anyone we introduce them to. All you have to do is go to advicechaser.com and just click on the link that says find an advisor. Once again, from Advice Chaser, thank you everyone for coming, and we'll see you at another webinar soon. Goodbye, everyone.
Thank you.
Thanks, everyone.